And the major slide of my presentation is the first slide. This is our acknowledgement and recognition for your mentorship and support along the years, not only to our group, but to many other groups. Oh, yes. I want please to clap you out. זה מגיע לך, באמת. So, this is our institute. It's a 10-year-old institute in the middle of Necker Enfants Malades Hospital. This is the eldest pediatric hospital in the world, more than 200 years, just before Great Ormond Street. This is the first pediatric hospital, and it's a brand new building built by Jean Nouvel on the campus of Necker Enfants Malades Hospital. And seen the institute from the outside, and this is the concept of the institute. It's a very original concept. The concept is to bring together under the same roof all the protagonists of a given project. So this is the institute from the inside. The outpatient consultation is the first floor, 35,000 patients with genetic disease or at risk of genetic disease in the atrium, with dozens of doctors specialized in genetic conditions. And so an outpatient consultation, the biobank, the data warehouse of all the files. We have 1 million patient files in this database. And all the floors above are research teams, recruited on a competitive basis from all over the world. It's a very competitive positions, well endowed, but very competitive. And in a nutshell, we have the conference room, we have a technology transfer office, we have the platform for sequencing, imaging, etc. And so the patient benefit from the research unit in the upper level, and the scientists know why they are here. They are here for the sake of the children. So this is the concept, and we are very, very proud of this. And this is a typical odyssea of a patient coming at imagine for a genetic condition, including Friedreich ataxia. So the child is coming with a family. We see 35,000 patients a year, and we have several reference centers. When he has been seen by the doctor, the blood sample is taken immediately. One child, one stick, and that's done. And DNA is stored in the biobank, and it goes for sequencing if needed in the service laboratories. And then the question raised, is the gene known or is the gene unknown? So if the gene is known, the child has immediate access to any clinical trial, because we have a department of clinical investigation, which welcome partner and industries for collaborative studies, and the child would be included in the given protocol with the promotion of INSERM or the hospital. And this represents 80% of our clinical trial at the Imagine Institute. There's a total of 150. So 80% are collaboration for existing drugs with companies. And when the circle is complete, then the benefit of the drug return to the child. This is when the gene is known. When the gene is known, but we have no offer on board, the case is advertised to others, to other scientists interested to include patients, and this works very well in the European context because we are part of the ERN, European Research Network, and some of our patients with no given offer on board are referred to our colleagues abroad. Now, if the gene is not known, then it is taken over by a research team of the Institute. We have 28, and it goes through the genetic platform, and if the gene is found, it's fine, and we shall discuss this. But if the gene is not found, we have a boîte aux lettres, a mailbox, where we can post all our unknown variant, looking for other cases to build cohort of patients for observational or interventional research. And if the gene is known, and if we have enough patients, and this is very helpful to have the data warehouse, because among 1 million cases in France, we often can find other cases, and build a clinical trial on a number of cases. And then come the functional studies, preclinical studies, and we are exactly here on my purpose today, and we will end up with a clinical trial, internal clinical trial. And this is what I'm going to tell you today. And this is the last slide of Agnès, and my first slide of my talk. I am exactly here, being a pediatric geneticist. I am in charge of launching this clinical trial with artesunate. I remind you her taking home message. Artesunate can induce transferrin receptor palmitoylation and non-transferrin bond iron transport. It reduces iron content. You have seen her result. And it rescues endosome recycling in patient cells. This was enough for me to try to launch a clinical trial. Artemisinin, artesunate, you remind us that it is a derivative of artemisinin.
Nobel Prize?
Yes, in the 19th century or?
No. Nobel Prize 10 years ago.
10 years ago. Antimalarial drug that cross the BBB and induce the transferrin receptor palmitoylation and reduce iron overload. So the clinical trial was coined Artemis for obvious reason, and it's a phase 1-2 clinical trial aimed at checking the efficacy and tolerance of the drug. And this was the major endpoint. Would it be tolerated? And the primary endpoint was the effective dose needed to reduce iron in PBM cells of the patient in vivo. This is not the in vitro experiment that Agnès has shown. This is an in vivo clinical trial, and it's a dose escalation study. So you give increasing amount of the compound week after week until the point where you reach the first decline of PBMC iron. So this work is based, have to render César what's César's. This is the previous work of Krishna in UK, who is a pioneer of the use of artesunate. Sanjeev Krishna did enormous work, you're right, on the benefit of artesunate in colon cancer as an adjuvant of chemotherapy in colon cancer. And I have talked a lot with him to know what would be the best dose to try in my patients. So he gave me these advices, 1, 2, 3 to 4 tablets, so from 25 to 75 or 100 milligram. And
this is because they have a high level of transferrin receptors.
In the condition. So this is the rationale.
The rationale.
So each phase, we have included 20 patients, all boys, to prevent for anti-conception drugs in this young chap, age 16 to 60, and they have been all included, 20, and there are 3 levels. We have a T0, and then 1 week on and 1 week off. And after the first week, we assess the iron in PBMC. It decreases, the patient is stopped, and if it is not decreased, it continues for another sequence of on and off, and then a last one. So in all, it was a maximum time frame of 2 months. This is a very short, it's a very short tolerance efficacy, just to see whether it's not deleterious in the context of Friedreich ataxia. We knew that it was not deleterious in colon cancer, but who knows whether it is also non-deleterious in Friedreich ataxia. It has to be tested, and it went fine, and all patients responded. The 7 or 8 responded to first dose, another 8 to the second dose, and 4 to the last dose. And this is the iron concentration. No obvious impact at the first and second level, but a decrease at the third level. And this, in short, and this is the end of my first part, we have registered no short-term, 2 months, clinical or biological adverse effect of oral artesunate. We found detectable level of dehydroartesunate in the plasma of the patient. This is for David. This is a pharmacological assessment that the active compound was indeed detectable in sufficient amount, and this is the case. This has been done with the help of Centre d'Énergie Atomique, CEA, and they were very nice with this monitoring. And again, this is based on the prior work of Sanjeev Krishna in colon cancer. The primary endpoint not only showed a certain degree of variability of iron concentration in vivo, which is a difficult test in vivo, but a downward trend of cellular iron content at the higher dose. Agnes is currently doing a secondary endpoint assess, because all this is very new, an assess doing quantification of intracellular ferritin during the trial, because you have seen that ferritin follows the same trend. You may ask why we did not directly study the transferrin receptor. Simply because the level of transferrin receptor expression in PBMC was extremely low, very low. We couldn't find any, so it was very difficult. So we could not use this criteria as an endpoint. And this is why Agnes mentioned at the end of her talk that she's doing an ongoing proteomic analysis on the level of palmitoylation in patients, fibroblasts, and PBMC following the trial in collaboration with a scientist from Bordeaux. So my question, and she has already addressed the question, we don't pretend to cure all the symptoms of Friedreich ataxia. And the question, the major question is to know to which extent does palmitoylation defect account for Friedreich ataxia symptom. Depending on the landscape of the impact of depalmitylation will depend hopeful impact on the dysfunction. But we don't know. What we know is that there are a big number of proteins in the brain that are palmitoylated, supposed to be palmitoylated. So maybe we hope that we shall have an impact, a partial, sequential impact on a fraction of the multi-impact of frataxin deficiency. So the next slide, of course, the next step is, of course, a phase 3 clinical trial. The first trial, phase 1 and 2, has been sponsored by families and donors. It cost me 150,000 euro total, 150,000, which is not enormous, frankly. I don't know what you think.
Very, very low.
Very low. But usually other clinical trials in the UK in particular are extremely expensive, millions. But we managed to have this 20-patient trial for 150. What is it?
Only 2 months, per se.
2 months, yes, that's right. This is why, because it was very short. That's true, exactly. So the next step is a phase 3. We are trying to attract companies to get the patent that we have deposited and to use our patent to launch a trial. As a clinical geneticist, I am concerned about the endpoint, the clinical endpoint, not only in Friedreich ataxia, but in all your conditions, my friends, because my sense is that the usual endpoint, clinical endpoint, are very, very late stage. And I'm looking for much early stage indication of a slight clinical benefit. And we are currently doing 3 clinical trials in Friedreich ataxia, one on the impact of any drug on the voice, frequency and amplitude. But I have no time to comment on everything today. I want to comment on a work that we are doing with a good colleague of us, a neuroscientist from Paris. He's German and Polish. His name is Florian Wasszak. He's a specialist of reaction time. And I want to show you the preliminary result we got on reaction time in Friedreich ataxia for your information. In a nutshell, the reaction time is a very easy test, neuropsychological test. The person is sitting in front of his PC, and he or she is asked to react as quickly as possible to a stimulus on the screen using a keyboard. And the reaction time is assessed several dozen of times. So the standard deviation is very, very low for a given patient. Not only that, but you can repeat it even remotely from home. So in the case of a clinical trial, we would ask the patient to be monitored remotely from home. And I want to show you what the simple reaction time is. The patient is sitting in front of his computer, and he will have to react to a simple visual stimulus with two components, a reaction time and a motor time. The first component is the reaction time. The patient is pushing on the button, and when the light is on, he has to withhold and this is the reaction time. And then he has the movement time. He is asked by a light to press the button again, and this gives the movement time. And this is the result, the preliminary result in the Friedreich ataxia. And you can see in red Friedreich ataxia, in blue the control, age mentioned, that the reaction time and the movement time are significantly longer in Friedreich ataxia. This is not a big surprise. You know those poor children. They are very smart, but they are very slow. They slowly answer to question, and they slowly execute movement. But it will be a early stage endpoint for any clinical trial, because what my sense is if one day with any treatment, this one or anyone, if we have a benefit, the earliest positive, hopefully positive result would be obtained with very tiny nerve and tiny muscle like voice or transmission, neural transmission. So this reaction time and some other component like the go, no-go task, I don't want to take you too time, all this is fully significant, P000. So, and one last test that we are using for them is the Simon task. In the Simon task, the participants respond to a non-spatial feature stimulus appearing on the left or the right side of the screen. And the responses are known to be faster and more accurate when the stimulus and response side match. It's called the congruent trials. And this is better than when they do not. It's the incongruent trial. And this is why we see again in the all response congruent and incongruent trials a significant difference between control and Friedreich ataxia. And this is, and you know that very well, you are neurologists and psychiatrists, that the cerebellum plays an important role as it supports coordination and timing of cognitive operations, suppression, irrelevant spatial information, adaptive response, etc. And again, the Simon test is significant. Briefly, you see that in abscissa you have the triplet number, and the standard deviation correlates with the number of triple. There is a linear correlation, not in absolute value, because there is a big dispersion. Patient by patient, you have a very big dispersion, but when you plot the number of triplet as a function of standard deviation, you have a better correlation. So apparently, the larger the repeat, the more severe the impact on the function. So I want to conclude to just say that this clinical trial, Artemis, in the pipeline of imaging is exactly here. It's a novel therapy, and it is in the this is in the pipeline, the 150 pipeline. We have novel therapy, repurposing, diagnosis, and digital. Clearly, this is not a novel therapy, but this is a repurposing, as you have mentioned earlier. And Artemis is here. It's obvious that when a drug is existing, it's much faster than a clinical trial starting from a discovery. So we capitalize on this approach, repurposing, when we understand the benefit, potential benefit of a drug. And this is the most numerous and the most advanced, not only this trial, but other from my colleagues from Imagine, is the repurposing of existing drug once you understand better the pathophysiology of the disease, which is the case here exactly. So I think this is my last slide. I'll skip this one. And again, thank you very much for this invitation. It's a beautiful opportunity. Thank you.